Polycystic ovarian syndrome and endometriosis are everywhere in the news right now. Our guest today specializes in these conditions and is here to help us understand the impact on our fertility and the hope and path forward. Our guest is Dr. Minoos Hosseinzadeh, or Dr. H. She is the founder and director of the Fertility Institute of San Diego and a nationally recognized expert in reproductive endocrinology and infertility, or REI. Dr. H received her medical degree from Laval University in Quebec and completed her internship at McGill University in Montreal. Dr. H is one of the members of the Society of Reproductive Endocrinology and Infertility, and there are only less than 800 physicians in the entire United States who have received this honor. The Association of Reproductive Endocrinology and Infertility has very strict requirements for its members. She has received special honors at several national and international conferences and authored several papers on hormone replacement therapy and age-related female infertility. Dr. H is fluent in English, French, and Persian. With over 20 years' experience, she has made countless families' dreams come true, and we are honored she joined us for this webinar today. Welcome, Dr. H.
Hi, Karen.
Hi. So we're going to go ahead and get started. This is a hot topic. It's all over social media, and I'm thrilled that you as an expert get to join us for this conversation. So first, what is PCOS? What does it stand for? And then we'll get into how common is it and what are the symptoms. But what is PCOS?
Well, thank you for having me, Kara. I'm delighted to be here. PCOS stands for, so it's PCOS, and it stands for Polycystic Ovarian Syndrome.
And what exactly is that?
So polycystic ovarian syndrome is a very common hormonal disorder found in up to 1 in 10 women. And it has a variety of presentations, and those can range from oligomenorrhea or anovulation, which presents with irregular bleeding. Women can skip periods. Typically, they go more than 35 days in between periods. There's hyperandrogenism, which presents as hirsutism, and that simply means there's excess hair growth. But the hair growth is usually in a man's distribution, so sideburns, upper lip, chin, midline neck, and midline chest. Patients can have acne. That's very common in polycystic ovarian syndrome patients. They have weight gain, and most are overweight. However, you can have patients who have polycystic ovarian syndrome and are thin, and insulin resistance is commonly found. So the diagnosis of polycystic ovarian syndrome is made from the questions that the physician asks, the history on physical examination, looking, for example, for the hirsutism, blood work that we do to check the androgen levels, as well as an ultrasound, which looks for these very small follicles, and they usually present around the edge of the ovary, and there's a classical string of pearl sign that we see, and that is what polycystic appearing ovaries are on ultrasound. To be diagnosed with polycystic ovarian syndrome, you need 2 of 3 criteria. And those are, one is anovulation or not ovulating, and that is when patients present with irregular periods. The second one is signs of hyperandrogenism in your blood work, so elevated testosterone level, for example. And the third one is the polycystic appearing ovaries on ultrasound. And just a word of caution, so we say polycystic, but these are not truly cysts because they don't meet the criteria of cysts. So these are really small follicles, which are the homes to the eggs that start to grow, and they stop in that process. They don't complete the process.
Okay, before we get into how that can affect fertility, let's go ahead and talk about what endometriosis is and how common is it, as well as what are the signs and symptoms. Then we'll cover everything else regarding both of them.
So endometriosis is also very common in women, found in up to 10% of women. And endometriosis is a condition where the lining of the uterus, which is supposed to be inside the uterus, is found outside of the uterus. It's found commonly on ovaries, fallopian tubes. It can be found behind the uterus in what we call the posterior cul-de-sac. It can also be found on small bowel, large bowel, as well as the bladder. Rarely, patients can have a more distant location of the endometriosis, such as the lungs, as well as the belly button, for example, or in scars or adhesions. The most common symptom is pain, and patients can present with, your classical triad of pain symptoms, which are dysmenorrhea, which is painful periods, dyspareunia, which is pain with intercourse, and dyschezia, which is pain with your bowel movements at the time of your cycles. And another, of course, common symptom is infertility. Patients present with infertility. And the reason why patients have the pain symptoms is because every month when you have a cycle, the lining of the uterus breaks up and it's shed. Well, with these lesions of the lining inside the pelvic cavity, every month these lesions also go through the same hormonal changes in that there's microscopic bleeding, which leads to inflammation and eventually scar tissue formation. And, the most important thing is to have a very high index of suspicion for the disease when someone presents with painful periods, because the goal is to be able to treat or manage endometriosis early enough so that, when someone gets into their 20s or 30s and is thinking of having a family, hopefully their endometriosis hasn't reached a stage where it's stage 3 moderate disease, stage 4 severe disease, where there's a lot of scar tissue inside the pelvic cavity, the abdominal cavity, and it makes conceiving quite difficult. So it leads to scar tissue, it can damage the tubes can become blocked. And in the early stages of the disease, also, it does have an effect on fertility because these small lesions secrete cytokines, which are the ovaries, they get the fluid, the peritoneal fluid gets into the fallopian tubes. And as a result, it's not the best. But typically in later stages, it's a structural.
What options do people have who want to conceive but have been diagnosed with either PCOS or endometriosis?
So the nice thing is that if you have been worked up adequately, there's treatment for both patients, PCOS and endometriosis. And I can't stress enough, Kara, the importance of an adequate workup. So for PCOS, if they have underlying insulin resistance, the most important thing is to correct that first. And as I said, a lot of patients will start ovulating on their own. If we correct that problem, or if patients do not have insulin resistance, then we usually resort to ovulation induction medications. And we use the simplest forms of treatment that we have for these patients. And my go-to is letrozole. It's an aromatase inhibitor. It's a pill that patients take for 5 days. Some physicians like to use Clomid as first line. Again, that is also a pill that they start 1 pill a day for 5 days. And for us reproductive endocrinologists, the best way to assess someone's response is by monitoring these patients. So the only way that we can tell if you're responding to that dose of medication or not is by doing serial ultrasounds. And that will also help us to time whether it's a timed intercourse cycle or an IUI, intrauterine insemination cycle with a trigger shot, for example. And, I sometimes say to my patients, if you had to pick a problem, PCOS is one of the good ones to pick because it's one of the easiest ones for us to take care of, as long as there aren't any other major issues going on. And of course, we do a complete workup, the partner, the fallopian tubes to make sure they're open. But usually most patients with polycystic ovarian syndrome are able to get pregnant very quickly. If the pills don't work with ovulation induction, then we do have more powerful medications. I'm always very, leery of using that because they're powerful and it can lead to multiple follicles, sometimes too many follicles growing, in which always in vitro fertilization, where we harvest the eggs, create embryos, and only put back one embryo at a time. So elective single embryo transfer. So those are the basic treatments that we do for patients with endometriosis. The incision in the belly button, we go in with a lighted telescope and we look inside, and we're looking for these lesions of endometriosis, and we're looking for scar tissue. At the same time, we can assess if the fallopian tubes are open. A couple of decades ago, we were doing a lot more laparoscopies than we're doing now for that. And in general, if the basic fertility evaluation, egg, sperm, fallopian tube is normal enough, then we try ovulation induction with them. So similar to the polycystic ovarian syndrome patients with fertility pills and either timed intercourse or IUI have moderate to severe endometriosis, where there's a lot of damage inside with respect to scar tissue or, blocked fallopian tubes, for example. They are candidates for IVF. And the beauty of IVF is that all you need to have a baby is really one ovary and the uterus, of course. So if the patient has lost an ovary because of an endometriosis chocolate cyst, or even if both of the fallopian tubes are blocked, it doesn't really impact IVF success rates that much. So we harvest the eggs. We only need one ovary. We're lucky in that we have a spare, and we create embryos, and we put back one embryo at a time in the embryo transfer procedure. If a patient fails ovulation induction, and usually we say 3 to 4 maximum cycles of ovulation induction with the pill, then they automatically would move up to the next step of IVF.
Okay, so that kind of answers my question. If it's safe to conceive with endometriosis and PCOS, based on everything you're telling me, yes, it is. If you're unsure, definitely talk to your doctor. Is there anything people with either condition should do when trying to conceive to increase their chances of getting pregnant?
So with polycystic ovarian syndrome, lifestyle is very important, and the choices is important. Exercising, patients that are overweight, weight loss of 5 pounds or 10 pounds, that can be sufficient sometimes to make them ovulate on their own. The definition of infertility is the inability to conceive after a year of trying, 35 and older, after only 6 months of trying, and our biological clocks that we're fortunate with someone who is not having periods, who's having, a cycle every other month, 3 or 4 cycles a year. They really should not wait to meet the 1 year criteria or the 6 criteria, because they're not ovulating at all. So they should seek help soon. But in the interim, the lifestyle changes are very important. For women with endometriosis, one of the best forms of treatment is actually pregnancy, because the progesterone levels are so high. But leading up to the time of trying to conceive, being on birth control pills also maintains the endometriosis in a holding pattern. So once they're ready to start trying, if they find that their pain is getting progressively worse, period after period, the dysmenorrhea or painful periods are getting worse, the dyspareunia or pain with intercourse is getting worse, or they have GI and bladder symptoms with their periods, they should be seen sooner,
Okay.
because that's usually an indication that the disease is progressing.
Mm.
So we don't want to wait till they get to moderate to severe disease. And at that time, the only option would be in vitro fertilization. But if I may just stray a little bit for
Yes.
thank you for all the mothers out there. If you have been diagnosed with endometriosis, if you've had painful periods as an adolescent, then there is somewhat of a higher incidence of endometriosis in your daughters. So
Okay.
preventively, the key thing is to be, your daughter's advocates if they start complaining of these symptoms, to make sure that they're checked, that there are no other issues going on. And, the goal is to preserve their fertility as much as we can. And birth control pills is one of the best things to be able to do that. And I always have this discussion with my patients, once they graduate from us, and especially when we know that they're having a daughter, so that they can be on the lookout for these symptoms.
That is so important to share, having them be advocates as early as possible and letting them know, and removing the stigma around birth control for its sole purpose. It can do so much more, and you gave the perfect example of that. So thank you for sharing that. Is there a point in someone's fertility journey where you believe that they've reached a point where they really should consider third-party reproduction? Maybe nothing else is going to work in your opinion. Is there something that kind of shows you that? Or is everyone really a good candidate for these other things you've talked about beforehand?
So going back to what I said earlier, it's important to do a comprehensive workup on these patients. Egg quality, sperm quality, the three-dimensional structure of the uterine cavity, the fallopian tubes. And a lot of times we find that, the diagnosis is not just limited to one issue, but it could be multiple issues. For example, a 39-year-old patient who we suspect has endometriosis, or we know has endometriosis. If her AMH level is really low, and that's a blood test that we do to assess ovarian reserve, or for example, if her antral follicle count is really low, and that's another test to assess our ovarian reserve and egg quality. And if they've failed IVF or considering the most successful form of treatment, in these patients, when egg quality is a major factor, then one conversation we should always have is to also discuss egg donor. So potentially using an egg donor in her mid-20s to late 20s, harvesting the eggs from the egg donor, mixing it or doing the ICSI procedure with the partner's sperm or with donor sperm if it's a single woman, creating embryos. And as long as her uterus is normal, to transfer that embryo into her own uterus so that she actually gets to conceive, carry the pregnancy, go through childbirth and all of that. By the same token, if we find an issue with the uterus, or someone either with polycystic ovarian syndrome or endometriosis presents with recurrent miscarriages, which has had a complete workup with recurrent pregnancy loss, as well as aneuploidy screening of embryos. Sometimes for those patients also, we don't have a choice but to offer surrogacy. Which is wonderful, because as long as their egg quality is normal, they're still having their own biological children. If someone has a major uterine abnormality, such as a heart-shaped uterus, a bicornuate uterus that we can't really surgically correct, then naturally they would be candidates to use a gestational surrogate or a gestational carrier.
So if I go to a doctor like you, Dr. H, and we do a complete workup, I will know all of those options because you're going to be able to look at everything and really assess and evaluate and give me guidance to make an informed decision.
Absolutely. I always say our job is to empower our patients with knowledge, present you with all of the options available to you so that you can decide what's best for you. And, that's really the basis of an informed decision.
I don't think there's a better approach than that. I absolutely love that. A couple questions we got on social media when we advertised for this is, are the tests that they need to go through for fertility or endometriosis, are they painful? A lot of people are very concerned about what they need to go through to have these tests done. So are they traditionally painful for most patients?
So I'd like to say no. So no to the blood tests that we have to do, the transvaginal ultrasound that we have to do, the semen analysis for the partners that we do. The pain only comes with evaluation of the uterine cavity and the fallopian tubes. But I think if a patient is adequately prepared, and, I'm a firm believer of why suffer when you don't have to. So if we pre-medicate our patients with non-steroidals an hour before the procedure, give it long enough to act, I think patients do quite well. And of course, it depends on someone's pain threshold as well.
Yes.
Some have lower pain thresholds, some have
Yes.
higher pain thresholds, but I think overall patients do very well.
That's wonderful. Now, another question we received is, and this may not relate at all, but because we're talking about PCOS and endometriosis, and they were asking about egg retrieval, does either condition make egg retrieval any more painful when that's occurring? And my hope would be no, because of medication and things like that, but I'd like to ask you.
Certainly. So the beauty of doing egg retrievals under IV sedation is that the patient is completely asleep. She doesn't feel anything and she doesn't remember anything. She will remember going into the operating room, and then the next thing she'll remember is waking up in recovery room. So no, the answer for during the procedure. After the procedure, and this is not always a bad thing, patients with polycystic ovarian syndrome, because they have usually so many follicles to begin with, they tend to be better responders. So they have more follicles grow. So they can have more bloating associated, in the days leading up to the egg retrieval and for a few days after the egg retrieval. But we have such wonderful medications now that we can use to try and minimize that. And also it's nice to be able to just go through one egg retrieval and hopefully harvest as many eggs and create as many embryos so that, the patient is set forever. But I wouldn't let pain be a concern. And even for after the procedure, patients are prescribed pain medications, which more than adequately controls the symptoms.
I think that's going to open up so many doors, because the fear of the unknown is a really big factor in making decisions. And the calmness and comfort with which you answered that even brought my own concerns down. And that was beautiful. Another question that came on social media is, I've been diagnosed, not me personally, this was the question. I've been diagnosed with endometriosis and it has spread a little bit further. If I get pregnant, will it stay? Will it hurt during pregnancy? What do I feel any more pain having endometriosis and being pregnant, or does it come down because of the hormone levels that you mentioned earlier?
So excellent question. So the beauty of pregnancy is that your progesterone hormone is usually very, very high. Progesterone is the hormone that shrinks the endometriosis lesions. Estrogen is what feeds endometriosis lesions and lets it grow. And because of the ratio of the progesterone to the estrogen, and the fact that for 9 months you're not going to be ovulating, pregnancy is one of the best forms of treatment for endometriosis. So our goal is to get our endo patients pregnant as quickly as we can. And another thing that's really important is once you deliver, and hopefully don't breastfeed for too long, because once you start cycling again, endometriosis has a chance of coming back and growing again. So once you're done with breastfeeding, the goal would be to go on birth control pills,
Okay.
hopefully continuously, because right after delivery, that's when you have the lowest amount of endometriosis lesions. And the goal is to keep that at bay and hopefully get you to the age of menopause, and then you won't have to worry about it as much.
One more final question. What should someone look for or ask someone when they are looking for a successful reproductive endocrinologist or fertility doctor? How do we interview to find out you are the right person for us?
So, the person has to be the right fit for you, because it is a relationship, and hopefully it's a long-term relationship. And you should be comfortable enough asking any and all kinds of questions, number one. Number two, you want someone who can completely assess you, because infertility is not just limited to one disease. So you should have a comprehensive evaluation. The history taking is important. So for example, endometriosis, a lot of the diagnosis comes from asking the right questions, the pain questions, the family history. Did your mother have endometriosis? Do you have sisters diagnosed with it, for example? And of course, adequate workup, whether it's blood work, ultrasound, or assessing the fallopian tubes. And the treatment options that are presented, for me personally, if I were a patient, I mean, yes, this is all I do for a living, but this is all I know in medicine. And when you go to other fields of medicine, you need to be able to understand what the physician is explaining to you. And also a big thing for me is the why. You should be able to understand and be comfortable with the why you're making the decisions that you are making. And I think when patients are, that's how we empower them with knowledge. And this journey is so much easier for those patients because they've been empowered enough to know the why, and they have chosen a path for that reason. And usually they know what the success rates are and all of those things. So I mean, I think those would be the things that I would look for in any physician, no matter what the field is.
That's the perfect answer. We've come to the end of all of the screened questions from the audience and social media. So I'm just going to open it up to you, Dr. H. Is there anything else you'd like to add for this webinar about PCOS or endometriosis or just infertility in general?
I think that if you're trying to have a baby, please don't wait. That's one of the most important things because of our biological clocks. Men have the luxury of making brand new sperm every single day. We, on the other hand, are born with all of the eggs that we're ever going to have, and they just sit there and they get older. So that would be number one. Please don't wait. Number two, if you have an interaction with a physician and you're not comfortable, or all of your questions and issues weren't addressed, by all means get a second opinion. So this is about a major chapter in most people's lives, and if the first interaction is not what you expected it to be, please don't stop there. You owe it to yourself to continue, and never give up hope.
Thank you. I think that's the best way to close this out. Dr. H, it's been a pleasure and honor to talk to you today, and I can't wait for more webinars because you're so informative and yet personable, and I think our audience really needs to see that. So I really appreciate you coming. Thank you.
Thank you for having me, Kara. I enjoyed it. Thank you very much.
We are honored to be a third-party reproductive partner with Dr. H. If you are interested in meeting Dr. H, visit her website at fertilityinstitutesandiego.com and navigate to the Contact Us section. If you would like to know more about third-party reproduction, including egg donation, or gain access to our egg donor database as a recipient parent, visit our website at FamilySourceConsultants.com or call us at 800-372-0529.